you to the Melbourne Law School, the School of Population and Global Health, and the Melbourne Medical School for your support of this collaborative. We really seek to try and find solutions for the way that law and regulation can help to improve health for all of our communities, and it's wonderful to see such a great group of people here this evening who share that goal of helping to improve health through law and regulation. I'm absolutely delighted to introduce the wonderful panel that we have here this evening. It's not often that you send out 4 invitations to your 4 dream panellists and all 4 of them accept. So we're very lucky to have our panellists here this evening. So sitting at the far right there, we have Associate Professor Caroline Johnson, who's an academic specialist in the Department of General Practice at the University of Melbourne. Caroline has been in clinical practice for 30 years, and I believe she particularly enjoys working at the intersection of mental health and primary care. She's also a very experienced medical educator and researcher. Welcome, Caroline. Next we have Professor David Storey, who's the Chair of Anaesthesia at the University of Melbourne. David also has a clinical practice, working clinically as a staff anaesthetist at Austin Health, and he leads a large program of research focused on the perioperative care of high-risk patients. So,
I guess one other thing relevant to this is I'm the incoming president of the Australia-New Zealand College of Anaesthetists.
incoming president of the Australia-New Zealand College of Anaesthetists, and we will be talking about the role of colleges shortly. Next we have Professor Ian Freckleton, who will be known to many of you. So Ian is a King's Counsel in full-time practice as a barrister across Australia. He has a very lengthy bio, but particularly relevant to tonight's event is his internationally recognised expertise at the intersection of law and medicine. He's served on the Coronial Council in Victoria. He teaches into the Melbourne Law School Masters of Health Law, and he's an editor of a number of journals, including the Journal of Law and Medicine. Ian was made an Officer of the Order of Australia for his distinguished service to the legal profession in the field of health law. Welcome, Ian. And I'm absolutely delighted that Linda has flown all the way from New Zealand to be with us tonight. So we have 2 Kiwis here. So Linda is a nurse by her professional training, but she's currently the head of clinical services for Somerset Retirement Villages. So Linda has responsibility for the clinical care and oversight of around 8,000 elderly residents across 37 villages, and Somerset is a New Zealand-based aged care company, but the continuum of care model that goes right from independent living through to hospital level care has been so successful that we have started building in Australia, and Linda welcomed the first 2 residents to her Australian villages just in the last few weeks, so that's really exciting. And I think that when we're talking about a shortage of healthcare workers, it's so important that we have representatives from aged care and primary care here, as well as David's hospital experience. So welcome, everyone. So this is going to be quite conversational in format, and I've said to the panellists, you know, if there are issues that are particularly dear to their heart, they're welcome to share them, and then we hope to leave a good amount of time for audience questions and discussion with the panellists at the end of tonight's event. So please think of your questions and save them up for when we get to that. But I guess we want to start with a little bit of a problem definition and understanding the scale of the problem that we're talking about when we talk about a global shortage of healthcare workers. I think Nancy has already given us some insights from Canada, but I'm really curious to know what's happening on the ground here in Australia. Some of you would have seen the slide that was up just moments ago, which is my own clinical practice. So for the last 12 months, I have been the sole psychiatrist for a population of 60,000 people working clinically just 2 days a week, to give you some indication of the severity of the psychiatry shortage that we're facing in New Zealand, which is particularly profound in regional and rural areas of the country. And I think that was one of the reasons for wanting to do this panel tonight, that as Nancy says, this is an issue, it's not theoretical, it's really relevant to the lives of many of us and our family members and loved ones who may be working in the healthcare sector and loved ones who are trying to access healthcare. So it has certainly been very real for me, that moral injury that comes from being in such a short-staffed service trying to meet immense needs. But I might start with you actually, Caroline, because I think, you've got on-the-ground experience as a general practitioner and presumably talk to a lot of GPs in your role. So I'm really curious to hear what you're hearing from general practitioners.
Well, this year I've tried to put a spin on it saying we've reached the nadir and it's only going to get better from here on in. We've got a lot of good ideas out there that people have been talking about that would make general practice better. But I do think in my 30 years it's the worst it's been. I mean, I came to this uni as a student, and when I came back here in 2002 to teach, I used to say to a class, 300 medical students, I'd say, look to your left, look to your right. One of the people you just looked at is going to be a GP. That's why GP's in the curriculum. And even then, you'd hear people laugh and snigger, and it's not going to be me. That culture has been there for a long time, especially at a relatively elite, high-performing university like Melbourne. But now I think that's even worse. What's really interesting is there's this move now towards, I've got children and nieces and nephews who are now in their 20s. They're now entering the workforce, and a lot of their friends are young medical doctors. And they're coming to me and saying, oh, Caroline, can you talk to them? They're interested in maybe general practice because the hospital is so horrible for them to work in. And I thought, what a terrible way to recruit people to my beloved profession that they're so traumatised by life in the hospital. So that's kind of where we're at the moment, not wanting to set too negative a tone because I do love my job, but we are at a pretty low point.
David, you've got a great perspective from what's happening in the hospital, and I guess, you're working in a large metropolitan hospital, and so I wonder if you're perhaps slightly better served than some of your regional and rural colleagues. I don't know if you've got comments on some of those disparities that we're seeing in workforce shortages.
So both my chair of anaesthesia actually covers about 15 hospitals affiliated with the university, including Shepparton, Wangaratta, Ballarat. And so we have quite a bit of insight into what's happening at those hospitals. And some are more challenging than others. We go back to the environments. So in anaesthesia, we have also the interesting situation where 50% of elective surgery in Australia is done in the private system. So a lot of anaesthetists work partly in private, some work purely in private, but some work in private in the public hospitals. And it's probably that split that's one of the issues. But like everywhere else, the single biggest problem is the regional distribution, particularly into rural and remote. And one of the concerns we have, there are a number of government-related activities at the moment that I'm happy to expand on later on if you like, that seem to be addressing workforce but not workforce distribution. And there's a little bit of magical thinking, I think, assuming that build it and they will come. So if it makes it easier for people to move their clinical practice to Australia, they will necessarily go to the country. But they're looking at purely at the numbers rather than the distribution.
Yeah, we'll certainly come back to that, David, because we are certainly interested in potential solutions and gaps that might be arising in those solutions. And now, Linda, I'm really, really interested in aged care because we often hear that there's this tremendous shortage of aged care nurses, but it seems that those policy settings can flip quite quickly. I'd love to hear what's been happening in New Zealand because we hear about these shortages all the time, but then somewhat paradoxically, just in recent weeks, I've also been hearing about aged care nurses who are looking for work in New Zealand and unable to find a position.
It's interesting, isn't it, how government settings can change, and some of the immigration processes in New Zealand changed, and now we've gone from a famine to a bit of a flood, and that's made recruitment actually more challenging because, as you say, it's not just a numbers game, it is a capability issue as well, and making sure you have the right people in the right job. And I think for me, I'm particularly passionate as a nurse leader and a manager of a workforce to make sure we have a safe workplace so people can practice safely and be supported in their work in an aged care setting. So it's been quite an issue to grapple with. Certainly we have not so much problem with the vacancies now in our aged residential care settings, but we're having to pivot and adapt to the capability and the support that those people need to practice safely in our environment, and a transition to practice safely in the New Zealand setting, which would be the same for most of us. So
yeah, it's fascinating, and I can see a number of people in the audience who have been really interested to hear as well that policy settings can switch on a really rapid flow of migrants like that, and then it raises this question about whether we're actually ready to support those people. And, you know, I've heard numbers like 100 nurses applying for one position.
We've certainly had that. You know, we've had 80 people apply for a position, and sometimes people are not really even sure of where that is in the country or what that might mean for living and lifestyle and pastoral care as well. It's really important when you're supporting a workforce into a new environment.
Yeah, that's really fascinating. Thanks, Linda. I'm sure we'll come back to the New Zealand experience soon. But Caroline, I'd just like to follow up on that kind of thread about what we're doing, because even within general practice, we're very reliant on internationally qualified practitioners. And I know we've got some people in the room with great experience around, for example, examining physiotherapists who are seeking to move to Australia. So I'm looking forward to an interesting discussion later. But it raises really profound issues about how we care for those people, and as Linda says, the kind of pastoral support and what we're doing to support them to adjust to the Australian healthcare system. You know, I'm curious on what's happening in general practice and whether you feel like enough is being done for newly arrived fellows.
So I've been around long enough to see the pendulum swinging back and forth, and I'm rather conflicted on this because I come from a refugee background. My mum came here as a 12-year-old with her two aunties as a refugee from war-torn Europe. So I'm very familiar with growing up with stories of people who come to a country and don't get their qualifications accepted or don't, you know, experience, you know, racism. The stories I got told weren't of racist Australia. They were told of the kind people who helped them navigate a basically racist system. And now I'm at the other end where I actually train doctors who have come from those countries and are now trying to work in Australia. And my impression is that they're excellent doctors, but they're not necessarily trained to work in the environments that we've put them in. And what we do is we put them in the least supported places we could possibly put them. Jared Ingham and I did a paper in the MJA a couple of years ago where we just sat down and looked at, well, what are the processes to support doctors in training and how much do you get depending on which system you're in? And basically, the less qualified you are from Australian experience, the less supervision you get. And there's all kinds of problems with power imbalance of what that supervision's like. So I don't think we've got it right, but I also don't think we've addressed the ethical problem of really stealing people from other countries where they also have workforce problems. And if we're going to do that, are we doing enough to make sure that we're helping the workforce problems in those countries? Because far be it from me as a child of a refugee to say you can't come to Australia because that's what my family did. But on the other side, I think we need to then be making sure that we're also contributing to those countries where we're really stealing from.
They're really interesting ethical discussions, and I did have somebody, you know, point out to me how much our use of language matters, and that it's often with those lower and middle income countries where we'll talk about stealing people, whereas for people like me, I guess, you know, I'm an internationally qualified doctor who came to Australia to work for better opportunities and better money. You know, that's seen as a very legitimate migration choice that I've made, and so, you know, it's really interesting the way in which we use language, but also those ethical implications for those home countries who have trained those practitioners and then lost their expertise. Yeah.
Just to add to that, the College of Anaesthetists is a trans-Tasman organisation, so a quarter of our fellows are from New Zealand. And if we really want to piss off the New Zealanders, it'll be to get New Zealand doctors to come and work in Australia. Because when we have a council meeting each year in Wellington, it's very, very clear how important attracting doctors from elsewhere to New Zealand is. And so someone called it sort of the Hunger Games, that, you know, you're trying to, but there is a major ethical issue of attracting, you know, doctors from, you know, lower and middle income countries to come and work in Australia, and their own communities missing out, and that is, I think, a major ethical issue.
So Ian, you know, you have this real depth of medico-legal expertise, and we sometimes hear that internationally qualified practitioners are overrepresented in medico-legal proceedings or in complaints, and it's certainly been a big issue in the United Kingdom where there have been concerns that the General Medical Council is disproportionately bringing disciplinary proceedings against internationally qualified practitioners, mostly practitioners of colour. I'd be really interested in your experiences. You've had involvement, you know, with disciplinary matters and coronial issues, whether you've seen this issue of practitioners being put in practice environments where they're not well supported.
Absolutely. And I was the lawyer member of the medical board and also the psychology board. So I've seen it from that perspective, and I've appeared for boards and disciplinary proceedings and many practitioners in disciplinary proceedings, so I've seen it from a variety of perspectives. What I've encountered is that the process of acculturation to Australia is not very well managed. It's incredibly stressful. Imagine most of us, for instance, going to Venezuela or Romania, and how difficult it would be for us to settle into a new country and to understand the nuances and perhaps be put in a responsible position, not just as a doctor, but having particular administrative responsibilities within a hospital outside the capital. We demand remarkable amounts of international medical graduates. And so it's far from surprising that they struggle from time to time, that their communication to patients and colleagues isn't all that it might be. And significant numbers of them really become stressed, pathologically or just generally, at being without the kind of support that they were expecting, without the kind of guidance that they need in a very unfamiliar situation. Again, what's been said already is absolutely right. Those who need most support and guidance tend to find themselves in rural and remote locations. I've spent a lot of time recently in the Northern Territory, and some of the practitioners in Alice Springs and then going into remote communities are just in shock at what they're dealing with, the kinds of disease patterns that they have, the limited support that they have, and that inevitably is going to flow through into the quality of care that they can provide. So those kinds of stressors are likely to flow through into poorer standard care, even though it may well not be deliberate, into complaints, sometimes into being sued, and also into some inappropriate behaviours, which people tend to engage in when they're under pressure. So all of those are recipes for problems.
Thank you so much, Ian. I was struck by your words, in shock, of people arriving in shock and the job not being what they expected.
Yes.
You know, Linda, I'm curious about aged care nurses who've come to New Zealand from other countries. You know, my understanding is sometimes they will have been working in a busy, fully staffed hospital where there are usually doctors who are directing their actions. You know, can you tell us a little bit what it's like for an aged care nurse to come from working in an international hospital to an aged care facility?
And we certainly are finding that more so now than we have, and I think some people literally do look shocked, and they can't believe there's no doctor on site, and they're practicing autonomously. And the person that they will be working with, if you have got the two registered nurses on a duty, are similarly experienced or inexperienced. And I think also that preparation for the role in the healthcare system in New Zealand or Australia, you know, our base training says that you will challenge and you will ask questions, and if you're concerned about a medication prescription, you will raise that flag. And for many of our different cultures that we work with, there is, you know, the male-female non-challenge, and then there is the you know, hierarchy non-challenge, and that acceptance that you deliver what is ordered. And so sometimes you'll see, you know, a run of medication errors, and if you look back at your roster, you'll see that people have not felt comfortable to challenge. And so that creates a really unsafe environment for our practitioners as well as for the residents. So that's something that I think we really need to address more systematically than we have. And it tends to be, I think, sometimes when you have new staff coming in, you might come into an existing team and you might only have one or two new practitioners coming into the team. That's manageable when they learn by experience and they're working with others who are more experienced. But if you have a large number of turnover and you get a newly developing team, we've seen that, you know, grow quite quickly into a problem for everybody. And it's very unfair on those staff, and it's unfair on the older people when any patients that we look after as well, isn't it? So, yeah.
And Linda, while you've got the microphone, we might actually just transition a little bit to one of our next questions, you know, which is, what does that mean for you as an organisational, you know, leader? Because all of these facilities need to achieve accreditations. There are standards that need to be maintained. Is that making it more challenging when you need to meet those accreditation standards if you're working with a lot of staff who are new to the country?
Yes, it certainly does, and I think very similar to Australia with some of your health and disability standards, we very much want to deliver a person-centred care approach, and that is what you are audited against, and that's quite subjective in itself to say what does person-centred care mean for you or me or for anybody else. So that I think teaching people those soft skills, understanding the culture of the people that they're supporting and how they demonstrate and plan care around that is something that we are seeing that we really need to do a lot of work to support the workforce to be able to assess and plan and deliver that approach, because this is people's homes in aged residential care, but they have complex comorbidities. They're very frail older people, as they are in Australia. The other people with lower support needs are living well at home, and people in the aged residential care setting are very frail and complex now, and they need highly skilled registered nurses. And so I think it's really important to pivot and to address that and to have, and I know that we will talk about emerging models of care or ways that we can support that in a more structured way going forward. Yeah.
David, I know you're really interested in accreditation, and it's in a slightly different context from aged care accreditation, where it's the facility that's being accredited against these aged care standards. But I know that the Royal Colleges play a role in accrediting sites as being suitable for training as well, and that this global shortage of healthcare workers has been affecting some of those accreditation processes at times. I'm curious on your comments on that.
If I may just have two quick comments. My view of the strategic aims of healthcare, and I think most have been mentioned about the individual patient journeys, public health, value being quality over cost, and workforce welfare. And when we think about these things, you really need to be taking all four into consideration. And I think we've mentioned all four at some point. At the moment, there's been the health ministers have got together and said we want effectively more bums on seats. And the College of Anaesthetists, along with the general practitioners and also psychiatry, are two that have been particularly, for want of a better phrase, targeted. So just for those who are interested, there are two major reports going around the public available. First is the Crook Review, spelled K-R-U-K, which is into international medical graduates and how they are managed coming into Australia, and that has had major implications for the colleges. And an example of that is that there are discussions with AHPRA at the moment that people who are largely comparable from the UK may completely bypass the colleges. So the colleges are responsible for training and professional standards of specialists, and remembering general practice is a specialty. We need to remind ourselves of that. That is our role. So we train or we oversee their training. But to go back to your question, there are training sites. A lot of the colleges, particularly surgeons and physicians, and to a certain degree the psychiatrists and others, have posts. So you might have the neurosurgical training post at the Royal Melbourne. We as a college accredit hospitals. So you need certain components. It usually comes down to staffing. Now, the National Health Practitioner Ombudsman, her role has been increased to include accreditation. On their website, you can find out about that. And they are focusing mainly on process. But what is unclear to me is who they think is being unfairly. They talk a lot about procedural fairness and everything else. It's unclear to me about who they think is being treated unfairly. You would hope they mean trainees, but I don't think they do. And the experience is that when accreditation groups visit hospitals and say to hospitals, you need to do this, this and this, it usually costs money. There may be pushback. And my concern is that by allowing more appeals and an appeals process, we may in fact find hospitals appealing the college's decisions around accreditation because they A, don't like the message, B, don't think they can afford it. So if we consider a hospital that I won't name that we de-accredited, it's a regional hospital. The problem was staffing, so it comes down to staffing, came down to behaviour, came down to the workforce welfare of our trainees, and we removed accreditation. Now, part of the problem with that was the hospital didn't tell the government to the last moment. And so in the discussions with the government, there is a belief amongst I won't say the minister, I'll say their advisors and some of the public servants, that we tell, the colleges tell a hospital on Friday that you're going to be de-accredited on Monday. And this was repeated many times in meetings. And so there's sort of urban myths running around about the behaviour of the colleges. And for various reasons, the colleges are seen, there's a perception amongst some that the colleges are elitist, men's clubs who want to exclude others and keep others out, including international medical graduates. And overcoming that perception is one of our challenges at the moment. So if we go back to accreditation, we are now looking at posts. We are now looking at a situation where we expect to have much. You could argue the procedural fairness and the components are important, but an appeals process in people who don't like the decision, and I think that could be very problematic, particularly if we want to withdraw accreditation, we're concerned about patient safety. And I think that's what's really important in all of this, whether it's looking at international medical graduates, whether it's looking at accreditation, it's about fundamentally patient safety, and then everything else flows on from there.
It raises such an interesting question about whether a community is better served by having a poorly functioning, short-staffed service or no service at all if you actually are making the decision to close a service. And I think those decisions around college accreditation can have real ripple effects. We've had an example in New Zealand recently where a service was staffed by one fellow of a college and 2 specialist medical officers and a number of registrars. The fellow left, and without a fellow you can't have registrars, which means that the registrars had to leave, and then the specialist medical officers, without any registrar support, said I don't want to be doing my job because I'm now being woken up every hour of the night because there's no registrar to do the calls. And so suddenly, through the loss of one fellow, they've suddenly lost all 6 doctors, which is almost an entire service. So I think there are lots of ripple effects from these
Similarly,
decisions.
The director of anaesthesia can't be the supervisor of training. So if you lose your supervisor of training and you've only got the director as the residual full-time person, you lose your training. Yeah.
Ian, as we talk about accreditation a little bit, I'm very interested in the legal responsibilities of both individual clinicians and also of the organisational leaders and boards. So I wonder if we maybe, I'm really interested in that tension, and I think certainly with the UK case of Bawagaba, we saw that playing out in the media, that a young female woman working in paediatrics, newly returned from maternity leave, came into the hospital, was effectively being asked to cover about 3 doctors' jobs. She had a supervising consultant who was not readily accessible. The IT system was down that night. A child who was critically ill had been switched beds without clear information about which child was in which bed, and crucial test results were not available. And yet she was effectively hung out to dry by the General Medical Council, to huge outcry and a lot of questions about where the legal system should place that balance between individual and organisational accountability when short staffing is contributing to failures in the quality of care. And really interesting interviews with the parents of the child who died, young Jack, who said that they really did feel that an individual doctor needed to be held accountable for the preventable death of their child. So, Ian, really interested in your reflections on where the legal system puts that burden of accountability on individuals rather than in systems.
There are perhaps 2 components to it. But in both, it's the individual practitioner who is especially vulnerable. If provision of care is inadequate, if poor decisions are made, it is the individual who bears ultimate responsibility. But almost inevitably, as everyone here will be conscious, individual decisions are usually made in a systemic context where there may be resource issues, there may be workforce pressures, there may be any number of things which can distort or erode the quality of decision making. And that's especially so where someone works in a relatively isolated way. And that can be isolated by reason of their role in an institution or by reason of their own circumstances. I think we mentioned gender issues earlier. They're really important, and they were in relation to Bawagaba. She was of Nigerian background. I get the impression she wasn't all that assertive a person by disposition. And she was somewhat deferential, and in an environment where she wasn't wholly familiar with the way in which the hospital structure was working. She'd just come back from a lengthy period of maternity leave. So if you incorporate gender issues, racial background issues, and relative inexperience, again, you've got a really toxic mix of dangers. So to answer your question specifically, Marie, it's the individual who is the primary focus generally in disciplinary proceedings, and this, with one exception I'll identify in a moment. And if someone's being sued, it's usually the individual with the institution, because that's where the money is. But the reason for the institution being sued is because of the individual's shortfall. So that shifts our attention to what the responsibilities are of an institution. Bawagaba is a classic case where everyone recognised that there were problems with the whole way in which the system was functioning at the relevant hospital. But it was Bawagaba and a nurse from overseas, from memory, who were the ones who ended up with their registration imperilled. And what happened to the hospital? Well, not too much. The only exception to what I'm saying is that there have been a number of cases over the years, and including latterly, where the chief medical officer or similar have been held responsible for the defective system that's been in place, and where they've been taken before their registration bodies, and in fact even had their registration cancelled, because they've been aware of the problems. They've been the one responsible for putting individual practitioners in an untenable position, and they've been the ones who could have done something and they chose not to. No doubt for a range of pressures systemically as well. So it's a shared responsibility, the individual practitioner, whoever the head is of an organisation, but also the entity itself. And the entity itself is often not the party which is sufficiently held responsible for or accountable for what's been taking place.
Explanation. Thanks, Ian. And I'm sitting here feeling a little bit nervous because I sit on a number of boards. So I'm a board member of the Royal Women's Hospital, for example. I think I may be the only board member with a current medical practicing certificate. And really what you're saying, Ian, is that for organisational leaders who are registered with a health practitioner body, there is an additional layer of accountability. You know, obviously all board members do have accountabilities, but I could potentially be accountable before the Medical Board of Australia as well if there were significant failings, you know, in the way that I was exercising my judgment about medical issues in that leadership role.
And it comes down to systems too, which are in place and which are enforced, because there are many situations, and I'm just thinking of something that I've been exposed to recently in a disability setting where some quite extraordinary practices were inflicted on a particular patient. And the entity itself is very responsible, and it didn't know about them. And the persons who were responsible for what was going wrong were low level. They were mostly from overseas, and they were almost all female. And they weren't telling people up the management chain. And they should have done, but they weren't, for reasons which are entirely understandable. And so the whole system wasn't working effectively. And of course, the person who lost out was the individual with the disability. So it comes down to processes and systems and accountability.
I'm going to pass the mic down to Caroline. Caroline, you're really involved in medical education, and I'll ask David the same question as well. You know, what are you telling students and trainees and perhaps junior colleagues that if they're finding themselves in a really short-staffed environment where the clinical demands overwhelm what they're able to provide and there are staffing shortages, you know, what do you suggest to people about how they respond in those situations?
Well, like most things in medicine, it depends. But if they're in a situation where they have to complete their training, it's really difficult to say, walk away, because you have to do your time to get your letters. But I will usually say make sure that you've documented it and spoken to a senior colleague so that they understand, because that's one way of saying, well, I did share the risk. And I say, I, as your educator, will make a note of it too. I think sometimes there can be a misunderstanding, so sometimes people can have a perception that they're being left in more risk than they actually are. It used to strike me a lot. I did a period of 7 months working in the UK, like a lot of young Australian doctors, and it always struck me as weird that the English doctors wouldn't ask for help, whereas in Australia we would have automatically asked for help. There was a real culture over there of just get stuff done, put in a central line, you don't have to ask for permission, whereas I came from an environment where you didn't even make a resuscitation order without checking with the consultant. I thought, what's that about? And there was a really strong perception over there that if you ask for help too much, it would reflect badly on your record. So I do talk to them about, well, what's the culture they have with their supervisor? Because if the supervisor recognises they're there for learning, they actually want to be consulting their supervisor. They want to be saying, I need help, because that's how you build good teams. If the culture's poor, then we have to have a different conversation about, well, what's the culture like? How can we fix it? Or can we get rid of this practice? But then we have the problem of, well, then we don't have enough practices to train. So it just becomes this vicious cycle. So as you can see, there's not a straightforward answer, but I do think sharing the risk with someone more senior and having it documented are very simple things you can do to mitigate the risk so that you don't walk away from something where we need you. So the last bit of this is always to say to people, what have you learned from this? And when you're in the position of being the supervisor, what are you going to do differently? Because that's the only way we'll ever get system change.
Thanks, Caroline. I think that's great advice. I had the great pleasure of working with Professor Ron Patterson for many years, who's a wonderful professor of health law and was the Health and Disability Commissioner in New Zealand. And in one very famous decision where a practitioner said, well, I didn't provide a reasonable standard of care, the patient was harmed, but there weren't enough staff and, I just didn't have time to do it because we were really short-staffed. And Professor Patterson's words have really stayed with me. He said it's not sufficient to toll the bell of scarce resources. That when devastating harm happens to a patient, it's not enough to say, well, we were short-staffed, I couldn't do anything about it. You actually have a responsibility, exactly as you say, Caroline, to ensure that you're escalating that you're making sure that it's known to others that those resources are insufficient and what the risks to the patients are. And I think we saw that incredibly tragic case in Perth of the young 7-year-old girl who presented to the emergency department with sepsis. The sepsis was not diagnosed, and the nurses said that they didn't have enough staff on that night. And the coroner's made really strong recommendations as well, that actually you can't just toll the bell of scarce resources, that our professional ethical responsibilities go further to trying to advocate for a safer system. But David, I'm interested what you suggest to your anaesthetic trainees, for example, if they're being put in a situation where, a senior person's not there and they're being asked to do something perhaps beyond their skills.
So in the moment, in the middle of the night, it's to call the consultant. I mean, we try and have, where I work at the Austin, we have fellows on overnight, so they're almost consultant level. Also, the nursing staff, I must say, are empowered. I mean, senior nurses will just call and say there's bad stuff happening, you need to come in. So that's an informal thing. I think the Austin's got a great culture, and I think that's part of that. But if we look more formally, it's one of the reasons why, for accreditation, you've got to have a different person being director and a different person being supervisor of training. And the first go-to, assuming it's a more systemic issue or one-on-one or something, then it's the supervisor of training. The college actually has a hotline that won't be immediately answered, but people can make online submissions. Sometimes they're anonymous, but sometimes they are trainees saying, I'm at Hospital X and I have a problem, rather than trying to call the college. And there's a group within the college, and as vice president, I sit on that. There's the CEO, me, and director of professional affairs. And we will respond to those maybe directly. The Director of Professional Affairs may contact the trainee. If we have major concerns, then we can have what's called an out-of-cycle accreditation visit. And so if we go back to sort of the new demands around regulation, you have an out-of-cycle visit that finds there are major problems. You say to the hospital, look, we're going to withdraw accreditation. We try not to, because for the same reason I'm saying it does affect trainees. So being a much larger group than general practice, probably the largest full-time department in a hospital is the Department of Anaesthesia. We have supervisor training who are the first stop. The college can be approached. But there's also a more collegial thing for the trainees as well, usually, unless they're in a small place. Sounds
like a great initiative. It was interesting for me when I was placed in this role, where, as I said, I was effectively being asked to do the work of 3 psychiatrists, and I spoke with somebody who does a lot of medical expert witness reports. And he said that as an expert witness, he has no way from reading your notes about knowing what else you were facing on a particular day. And he said it's actually incredibly helpful that if there's a day where slots are doubled booked because of a clinical emergency and there are no other staff to actually document in your medical record, decisions X, Y, and Z were made due to acute competing clinical demands. And he said that as an expert advisor on cases, if he sees those words or similar, he is actually able to take that into account. Ian, I'm not sure if you think that's sort of sensible advice, but to be trying to record at least a little bit of that contextual information if you're very aware that the care that you're providing is not what you would otherwise like to provide.
Yes, the documentation ends up being the best defence in the clinical record, and other steps taken to draw issues to the attention of the Chief Medical Officer or whoever, so that, as it was put earlier, the risk is shared to some degree. And so someone independent looking at it, be it a disciplinary tribunal, an expert witness, or a court, can understand that the level of culpability of the individual may be quite low.
Thanks, Ian. All right, well, we're getting sort of into the last, third of the session, so I'm really keen to talk about some solutions. And Linda, I might come to you to start with. So even though we've suddenly gone from a famine to a flood of nurses, I know that Somerset did a lot of strategic thinking about how to respond to a famine of aged care nurses, and that you've spent a lot of time thinking about different models of care or perhaps the role of technology, and I'd love to hear some of your reflections on thoughts.
So as many of you know, with COVID, we learnt a lot about virtual working, and some of those models, I think, emerged out of necessity and were perhaps not a planned response for many providers. And we were very lucky in Somerset, and I think one of the points to make is that we can't keep having health systems that just trade on the professional contributions of the workforce who are just dedicated and go to work to do a good job every day and sometimes stay quite late to make sure that good job is done. So that's not sustainable, is it? I think that's one of the paramount features for the healthcare workforce globally. So in Somerset, we're very lucky, and as I say, I think due to the diligence and the caring of our staff, that we've never run shifts with no registered nurse for our hospital care residents, but it became a bit of a norm across other providers in the country. And so they set up these virtual nursing services to cover those staff gaps. And while, as I say, we were very lucky to not be into that position, we are starting to establish a pilot this year of a national clinical support service that can be that clinical escalation in that virtual setting to provide clinical escalation pathways for our staff 24 hours a day, 7 days a week, and also some on-the-job training, so actually helping people with situations as they occur for them, because if you've ever started a new job and been given a policy manual to read, it's not very rewarding. And so I think, something a bit more practical and building that national skill set that can actually help people unpick what they're dealing with. And then over time, I'm hoping to give a bit of a gift to our primary care providers by having a national response there and having some of those out-of-hours escalations taken away from the primary care providers, because we recognise that they're as burnt out and stretched as we are. And so sometimes in the aged residential care setting, you only have 2 choices as to either keep them in the facility and manage them as best you can, or they go in an ambulance to the hospital, which is not the right place for them. The hospital's not going to add value to their journey, and we want that ageing in place model. So I'm hoping that this pilot that we're going to run in our South Island, we've got 6 villages to start off as a proof of concept for rolling that out nationally. And it's interesting, when we've mooted this change to our workforce nationally, everyone's gone like, no-brainer. In terms of that, and looking forward to that support. So that's just one aspect, as well as a transition to practice program.
Also kind of provides some career development pathways for people as well, doesn't it? That, for example, if you have a nurse who's a real expert on wound care, there's no reason that she can't be receiving high quality images of, emerging pressure wounds from residents around the country, and really using that expertise to provide a level of care that may not be available if you needed each of 37 villages to have an expert on wound
and
care.
I think our people living with dementia, you know, just having someone with more specialist skills there, over time I think we certainly will need a prescriber, you know, on board, and responding to end-of-life care and unmanaged symptoms of dying, I think, is a really key aspect in terms of improving outcomes for older people. So a lot of scope there, I think, to make that successful.
Someone from an emergency department nodding in the second row.
So please.
Yeah, absolutely. Caroline, or maybe David, you know, because you have an interest in intensive care as well, don't you, David? And I think some of those models of virtual support for smaller intensive care units have been operating for a while overseas, haven't they? Where you see these amazing images of an intensivist sitting looking at a bank of screens from small units.
There is no doubt, and we're looking at stronger relationships between regional hospitals and the major hospitals. Ben Thompson, who's been heavily involved in the surgical review, who works at the Royal Melbourne, we're looking at, he's talked about this for a long time, as have I, that, you know, formal relationships so that, you know, she can get on the phone to the Austin, you know, that there is known relationships and say, I have someone who has sepsis, and the Austin just says, send them now, you know, without question. I think there is a big role for telehealth. The other thing also in terms of people working in the country, and one of my colleagues looked at this, is we have, they're sometimes called interesting cases, other people call them mortality, morbidity meetings. But I mean, for us in anaesthesia, we often talk about near misses, where a patient wasn't harmed, but they almost were, but we got it in time. So they're the things, you know, we're very safety focused. And having joint meetings, say between the department and we had a discussion about this, Shepparton and Austin, sort of sharing cases and ideas. But the ability to know that you can just call someone and get help, I think, is important. And the telehealth component, you know, sharing images and sharing, direct information rather than someone saying, and I'll read out the results. I guess the other things, just while I've got the microphone, in terms of workforce, one is to try and get people perhaps to work for another 2 years. There's been, you know, how do you do that safely in anaesthesia or the procedural specialties, same in surgery. The other is, I think we as colleges need to ask ourselves, what can we do to make general practice more attractive, including particularly rural general practice. We have a program in rural generalist anaesthesia. We also now have a program in perioperative medicine that involves general practice. So things that we can do to make general practice, and of course, central to that is finding the right item numbers to support our, sorry, Stephen, but I thought you're the item number king. Providing the evidence for the funding, I think that's another component. So I think the important thing for us in the short term is to try and probably rebuild might be the right phrase, the relationship with the government. The ministers want this to happen, they want it to happen this year. And I'm a little bit, sort of the word pink bats is going through my mind, I must say, that things may be rushed. The other thing that really, really concerns me about this is the voice of consumers doesn't seem to be being heard at the moment. The Crook Review has no mention of talking to the Consumer Health Forum or others, and I'm very concerned that voice isn't being heard. You know, you were talking about what does a country town choose? You know, a slightly dodgy service or no service. Yeah. You know, what would they choose?
And I think we're probably going to have some quite robust discussions about that in Victoria as we look at consolidating the number of health services, because I think that many of the smaller health services are fearful that on a purely rational basis it doesn't make sense for them to have their own maternity service or their own emergency department. And so I think that having these conversations about how you can actually bolster the skills of the local providers on the ground. And so, for example, in psychiatry, one of the incredibly successful models has been to have a GP psychiatrist support service, because we just cannot accept all of the specialist referrals we receive from GPs. So we have a psychiatrist who is dedicated to answering calls from very skilled GPs like Caroline and Delanka, so that they can get advice from a specialist psychiatrist in a very timely way, without the need for them actually to come into the secondary service. Caroline? Yeah.
In the same way, I'd hope that a general practitioner could call a single number and speak to a perioperative medicine physician, such as an anaesthetist, with the same, I've got X who's going to have the hip replaced. What bits? I think I need to do X, Y, and Z, just confirming that.
Caroline, would that that help with your recruitment and retention problems if GPs were confident that they could access some expert specialist advice more readily?
Yeah, I do. I mean, I do think the idea of a consultant has changed over time, and now it's definitely quicker for me to write a referral letter and send someone off to a 6-week wait than it is to take the time to ring someone and ask a quick question, because I don't get paid for that at all. And we all know an average 3.5-hour session in general practice takes me 5 hours for all the extra things I have to do. The thought of ringing someone else for no pay, it's not very attractive. But I think coming back to the thought about aged care, because I started general practice thinking I was going to be a geriatrician. I thought, but I've missed the other things. I'll do general practice and I'll do aged care as a big part of it. And I'm sad to say that I've stopped visiting aged care for exactly the reasons. I'm not prepared to carry the risk, because I was getting caught, because I was a part-time academic. I thought, when I'm not there, I'd try and write very clear instructions of what I wanted to happen. So what comes down to, it's who's there to give the advice when I'm not there. So I got very sick of my patients being given inappropriate antibiotics and opiates when I wasn't there. And I thought, well, I can't be there 24/7, but if I can't rely on this extra workforce to do what I think is appropriate. And it's interesting, in our PHN that Stephen's our chair of, we've been trying different models of who gives that advice, like the nurse on call versus the ED. I've been quite impressed with the data of when you pay someone with more expertise, like an emergency doctor, to be answering the phone, you actually get, even though they cost more, you get better value for money, because you're actually talking about quite risky scenarios where there's, often incomplete information. And this, I think people need to not underestimate the training in diagnosis that you get from a medical degree that you don't get with most other health professional degrees. That's an oversimplistic thing, and I know there are many nurse practitioners who are great at diagnosis, and physios are great at diagnosing musculoskeletal, but that holistic generalist, when someone comes in with an undifferentiated, unrehearsed, impartial history, who's going to give you the best chance of not missing something really dangerous? It's someone who's really high up in their scope, and yet we often talk about changing the scope. I'm sure the ED, because EDs and GPs are the classic generalist professions where they have to know a bit of everything, not perfectly, but enough to not make mistakes. And that's the person I want answering the phone when my patient hasn't got me.
Yeah, really interesting. All right, Ian.
Can I take us back to near where we started? It seems to me that government has a responsibility if policy decision makers are determining that we need to import people from other countries. We need to do what is necessary to enable them to do their job effectively and without suffering very quick burnout or trauma. And so it seems to me that a combination of government working with the colleges should be doing quite a bit more to enable people to integrate and acculturate.
Thanks, Ian. That's a great transition through to kind of wish lists, because that's where I'd like to go for the final minutes before we open to questions. So,
well, just to add to Ian's point, I mean, federal government and state government, but also local government. How do you make a town or a regional city inviting for particularly international medical people? So I think, we tend to, when we think of government, well, I tend to think of the feds, but I think there's a role for all levels of government and community to make it safer for themselves. I mean, that's why it's in everyone's interest.
You do hear stories about small rural or regional towns who are at risk of losing their only doctor, who actually band together to find ways to provide great accommodation, or to find a job for the doctor's spouse, or to make sure that they feel really welcome in that town, and it actually makes a real difference. Yeah. Right, Linda, we're on to wish lists. What would be on your wish list in terms of addressing these health workforce shortages, and anything else that you'd like regulators or accreditors or complaints bodies to be thinking about that would support the work that you do? It is a big question.
In terms of a wish list, but as you say, I think it would be really amazing to not have everything sitting on the shoulders of individual practitioners. I think that there definitely needs to be in New Zealand in particular, funding for aged residential care is an issue. And, some of the systems that would actually help support those outcomes for older people do require a systematic approach that's well funded. And I think that aged residential care can play such an important part in the health system and could do a lot more for a lot of people to actually leave the hospital for the people that need it and have better capacity in the hospital for people that need it, if you actually value all the parts of the health system and get them working together. And in New Zealand, our ambulance services, which is the most critical thing people rely on when there's something really wrong with them, is still looking for funding from cakes stalls, basically. So it is bizarre, isn't it? In all the years that you do health, you think, I've never understood why that works like that. So yeah, I think for aged residential care in particular, to actually have a systematic approach that values older people in our care, I think is really important. I think in my bio, I talk a lot about rehabilitation and reablement and, people living well until they die. And I think that we don't have an environment that's well funded and resourced to be able to do that. So that could mean having people coming out of hospitals earlier, having a reablement approach for older people, having them be able to recover and be their best selves, and not have them end up living in aged residential care when they don't need to. So I guess it always comes back to me for the patient first, and having a really capable, competent workforce that wants to be there and do that job and is well supported to do it.
So much, Linda. Ian, what would be on your wish list? Sort of any medico-legal reforms that you think would help? Or
Some of the issues are financial, I think. We've just been hearing from Carolyn about the pressures on time and the impact that those pressures can have on the delivery of services and people's preparedness to provide certain kinds of care. It seems to me, again, talking about governments, that those contributions to provision of care need to be recognised in a tangible way, without an expectation that a 15-minute GP visit can conclude all that needs to be done for an individual patient. That's just fallacious. And if anything, the burdens upon people to do a variety of follow-ups are increasing. So that's an issue for government in recognising those components of work, and it flows over into retaining good people in the whole system. In terms of medico-legal things, there is increasing anxiety, I see, especially amongst medical practitioners, about their vulnerability to complaints and aggrievements. And there's a need for, again, support of people who are the subject of complaint, and construction of processes within systems where people are employed together to enable them to identify issues which they think are rendering them vulnerable to not providing the service that they want to provide. And that can be a really constructive feedback loop.
I love that as a takeaway message, that idea of vulnerability and what we can do to help people feel less vulnerable so that they will either choose to stay in their role or perhaps be attracted into that role. And Linda, your takeaway point about really keeping patients at the heart of this. And David, I loved your comment earlier about actually how much the patient and consumer voice has been missing from some of these discussions about these workforce shortages, and really how valuable their contribution could be. David, what's on your wish list?
I guess it's sort of the mirror image of less vulnerable, perhaps more empowered. So what is it that leads, across the board practitioners? I mean, I very much appreciate the point Caroline was making about recognition of expertise. I mean, here we are being academics, but I mean, clinical expertise, evidence that's what is quality of practice. That we use there's an acronym STEEP, so safe, timely, and accessible, evidence-informed, equitable, efficient. I think in these days, not only in time, dollars, and carbon dioxide equivalents, but particularly patient-centred. And that, if my wish list would be that the mental model that is used by regulators is the same as the mental model used by clinicians. That would be my single one. Yeah.
Which is going to require some more conversations between regulators and clinicians. Yeah, and I think we've heard quite a lot tonight that it's not just the quantity of health practitioners that we need, that there's a really important conversation to be had about the quality and also about the extent to which they're supported to adapt to the Australian context if they do come here from overseas. Caroline, what's on your wish list before we open to audience questions?
I guess if I want to finish on a plug that I think is important, I was reading the Health of the Nation report that the College of GPs surveys GPs every year and takes their pulse and they get, over 2,000 responses, so it's probably a reasonable sort of temperature taking. And 7 out of 10 doctors in general practice are feeling burnt out. Fortunately, their fear of medico-legal persecution is only 2%, but it was only 1% a couple of years ago, so it is doubled. But I don't think it's so much the fear of being persecuted, it's more the fear of the emotional impact of a complaint, even if it's not a real complaint. When there's talks of, well, we might publish on the website every complaint, even if it's found to be, not an issue. Because, mud sticks much better than good. So doctors do worry about all that. So I guess thinking about the well-being, and I struggle with this a lot as a teacher because, I think our students, experienced GPs who've been around, I've got GPs who've been taking our students for 20 years and they'll say to me, Caroline, they don't seem very resilient. They turn up late and they don't do this and they don't do that. And I just dread, I don't want to be that doctor who says, in my day, we used to get 2 hours sleep. And I don't want it to be like that, but I think, well, how can we prepare them for what is a really hard job? My 25-year-old said to me a few weeks ago, gee, Mum, because I was a part-time GP, part-time educator, he said, on the days you were in clinic, I just feel really sad when you came home, and I thought it was because I missed you, but now I realise it's just because you were so unavailable. Well, of course, I was listening to people's problems in 15-minute aliquots all day, people crying, people in distress. Of course, when I got home, I needed to just, not listen to my children's problems. And I think we need to be talking about how do you make people, and I see a lot of children of doctors, the old classic GP, the Doc Martin type. They have borne the emotional brunt of the work that their parents did as health professionals. We need to be thinking about strategies that actually support not just the doctor but the whole family, that you're doing hard work, you need some extra rewards. And it's not just financial, obviously financial helps, but I don't think having a lot of money in a nice house and a nice car really addresses the things I'm talking about. It's a feeling supported and feeling safe that matter.
Whereas the reward for my daughter is that she gets to sit in the back of a panel discussion. All right, thank you so much, Caroline. Well, we've got 15 minutes now for conversations, questions, comments. I know we've got a wealth of different perspectives in the room here. We have Anu here with a microphone, so if you just put up your hand before you speak. Comments, reflections? Yeah. Thanks, Jenny.
So I'm Jenny Peretz. I examine for the Australian Physiotherapy Council for overseas physiotherapy graduates. And we probably fail 80% of them. But it's so frustrating because if I could spend a month with them, I could get them up to speed. And COVID, they were given free mentoring in the hospital and private practices to help them understand the Australian health system. But because we're now so short-staffed, the staff are so burnt out, it's a vicious circle. They won't do it, but then they've got this potential workforce that could help them get the staff up there. And it's also, as a panel has mentioned, the attitude is different. Overseas graduates blindly follow orders, whereas David can probably attest that Australian physiotherapists are pretty assertive. So they have to learn to voice their opinion and be independent. So it's getting them up to speed there. But if we could just be subsidised to help there, we could get a whole new workforce.
Oh, thanks, Jenny. What a huge loss of human potential.
Yes.
Earlier, Stephen Duckett was telling me about a book. Is it called The Intruder? Which is based on the experiences of internationally qualified health practitioners who couldn't gain registration in Australia, and it sounds like a fascinating read for anyone in the room who's interested. Is that, if I got the title right, The Intruder?
I've emailed you the link. It's now available to download.
Great. Well, I think that hopefully Anu will be able to add that to the website page for this event tomorrow. Thank you so much for those reflections, Jenny, and good luck in achieving that support, because we so need physios, and it's just devastating and heartbreaking for those practitioners to not be passing the exam if they have the potential to do so.
They fail.
Yeah.
Less time they work in the system, the worse they get.
Absolutely. And Caroline, I think we see that with GPs as well, that GPs who've been out of clinical practice, it becomes harder and harder to then pass those clinical exams. Yeah, thank you. Other comments or questions?
So another thing that could help is they've recently offered an exam subsidy for people, because that's a big pressure. You come out of the hospital and you've kind of
created debts based on what you think you're earning in the hospital. When you go into general practice, you automatically take a pay cut. You don't get any maternity leave, anything like that. So they've now introduced things like maternity pay, continuation of service so you can get leave, and also some payment to help you sit the exams. I finished my medical degree in 1988. I was the last group of students who didn't have a HECS debt. And I think a lot could be said for saying if you choose an area of workforce where we really have a need, we will abolish your HECS debt. I have reservations about it because both my sons are art students and I think arts degrees are just as important as medical degrees. But I do think we need to review the HECS debt system for all kinds of professions, not just my own. But I think within medicine, I think saying we need more GPs in the country, I'm not talking about conscription or you have to go and work there, but I'm saying we could give you some fee relief in some way if you're prepared to contribute in that way.
But you can make it 50% to become a GP and 100% for a GP in the regions.
That'd be great.
All right, other comments and questions? Stephen.
So thanks. I thought it was an excellent panel, so thank you all for giving your time. Caroline, you said in passing that you thought that the University of Melbourne was a high-performing university. I think your criteria are unrelated to the way in which it meets the needs of the Australian population. Because I think we've got to, rethink what our objective of health workforce policy is. And my view is Australia needs to be net self-sufficient across all of the health professions. When I was in Queensland, I had the view that Queensland should be net self-sufficient across all of the health professions. And I also had the view that North Queensland should be net self-sufficient across all of the health professions. And I think we can go down to quite small populations of, say, 400,000 or so. And if we have that view, it really then begins to shape the whole flow into health professional education. And I think that's what we've failed in this country. We haven't set objectives, nor have we introduced policies to actually effect those objectives.
Yeah, I think that's a great point. And I should say, as someone who's struggled as being, I'm now an academic specialist in primary care because even though I do research, I've been told many times you don't do enough research to get promoted as a teacher and researcher, become a teaching specialist. I think there is a strong culture at Melbourne Uni of undervaluing teaching excellence. To all my teacher friends here, you all do a fantastic job, but try and get promoted on, well, you now can at least be teaching specialist. For the first 15 years of my career, you couldn't. And we know that our students here don't give us the best feedback on the teaching. So that kind of ties into your thing. If you're trying to create workforces that can work together, they have to have good experiences. To Melbourne's credit, they have created the Collaborative Practice Centre. I think that's the right name for it now. So they are trying to get people to work together.
Distribution as well.
But it's the distribution. So it's two bits of the puzzle. One is training people to work together, and what then is making sure they work. I mean, we did do it with the Crescent project of creating a clinical school in the northwest. So the Northern Hospital Epping wasn't once a Melbourne clinical school, and now it is. And we created longitudinal placements for general practice. So the students in the Northern were going to go there every week continuously. But of course, most of the longitudinal placements have been done anywhere else in the world with like 60 or 50 students at a time. Melbourne Uni decided to do it for the whole, 90 of them, and then a year later bring it to scale for 300 students. Very hard to get quality community-based experiences when you've got 400 graduates coming through a year. And I do think that's something we under-resource, but we expect really high volume, and I think that's a challenge.
I was just going to add, Stephen, it might also depend on what is by choice and what is by requirement, shall we say. The University of Melbourne, the Melbourne Medical School has a specific rural cohort, goes to a particular regional city, 30 students, none of them wanted to do their internship at their teaching hospital. So, there's some of the challenges in doing this.
What problem is that?
Yeah. Well, somewhat interestingly, from what I could work out, when we visited that particular place, was the training experience was great, but there were issues for what they were hearing from the junior doctors. That was one of the problems. So, to be fair, I'd say it's probably all of us. It goes back to, again, it may be a hospital that's affected by staffing and everything else. I think there may have been some cultural issues there, but we need to. It goes back to sort of the whole conversation. You can have that sort of setup and have that planning,
but it's not going to work unless people want to work there and stay there. And that's the real thing. How do we get people to want to stay there?
Yeah, thanks, Stephen. That's a good challenge for all of us to be thinking about workforce planning and design and what the barriers are. And I think in the Crook Review, they also spoke about the incredible importance of having accurate numbers and accurate forecasts and updating those and planning accordingly. So I think it's a great challenge for all of us. Any other questions, comments, reflections? Yeah.
I'm Kate Buckley. I previously worked for WorkSafe New Zealand as their healthcare liaison on good work design and mentally healthy work. Soon to be working at Peter Mac, so hopefully we'll be meeting a few of you in the near future. One of the challenges that we had in that work in New Zealand, particularly with Te Whaka Ora's complete huge agenda shift that happened with changing the healthcare system, was that people went, recognise mentally healthy work and good work design are important for workforce retention, but we cannot push it across the line with the boards. So I'm wondering if the panel had any insights into, within your jurisdictions, how we get people in positions that can actually make those decisions and change those systems to prioritise mentally healthy work and good work design for our workforce.
It's a great question. I've just been at the Australian Institute of Company Directors conference last week, and they were talking about the trends around legal responsibilities of directors, and that they were saying that the responsibility to provide a psychosocially safe workplace is likely to be one of the most significant trends in terms of director responsibilities. And I'm very, very curious as to how that will flow through to health service boards in Australia and in New Zealand. And it's interesting that you're from WorkSafe, because I've spoken about my role in New Zealand, and it's interesting that the National Manager of Psychosocially Safe Workplaces in New Zealand is actually really interested in talking to me about the impact of those kind of workforce shortages and the safety of people in isolated regional practices. And I see Ian nodding around those legal responsibilities of directors, because I think it is quite a significant trend that we're beginning to see, and there are quite strong accountabilities that come along with failing to provide those occupational health and safety things. So it's interesting to think about these, including psychosocial safety.
Yeah, at the risk of sounding like a lawyer for a moment, there's been a High Court decision which is enormously important. It happened to involve a lawyer, but it's as applicable to many other areas, where the High Court really clearly identified that excessive pressures and overwork and stress in the workplace can be foreseeably toxic and lead to harm, which is avoidable. And the trend in our occupational health and safety law is toward making employers more accountable for those kinds of deficits, because they flow through, first of all, to harm to the service providers, and then inevitably second phase to the patients.
Ian, I wonder if we could get a link to that case from you to add to the web page for tonight's event. That would be really helpful. I might get Anu to email and follow up with you, because I think lots of people would be very interested to read that, because I do think that legal and regulatory tools can be immensely powerful in influencing the actions of the health system. We've got a question down the front here.
My first question, what needs to be done in the immigration law to enhance quality and quantity of health professionals? One. The second one, Australia has given a great opportunity or chances to provide training for overseas students. So after they went back to their home, what was their contribution to this great country?
I think there are things that flow. If we are going to take the benefits of international health graduates, we need to look after people who come to Australia, nurture them, and create a culture and environment in which they might want to stay. But when they don't stay, to make sure that there are processes constructed so that they remain in contact with us, and so that what we have learnt from them and what they've been able to learn from us can continue to be a constructive exchange. Do you have some thoughts?
Interestingly, part of the Crook Review includes, things that, whatever is it still called immigration, or was that still Border Force these days? Well, whoever they are, that the immigration authorities facilitate entry, visa entry, and those sort of things. So the Crook Review actually has specific things for government to do as well as the colleges to do. And I very much agree that I'm particularly mindful of a Nepalese anaesthetist who came to learn anaesthesia for liver transplantation with us, and the ongoing relationships with those countries. I think Ian used a very important phrase, which is the two-way flow of information. That we need to be mindful that as Australians we're not telling our international colleagues how to do things. It's a two-way flow of information. Our college has a particular interest in working with people in the Pacific Islands, and I think that's a group I'm particularly mindful of, that we don't want people to come from the Pacific Islands, learn important skills, and prefer to be encouraged to stay in Australia rather than return home and maintain a collegial network with Australian colleagues.
Agree.
Yeah, okay.
Fantastic. Thank you so much, everyone, for coming along tonight, for your thoughtful contributions, and thank you especially to our 4 panellists for a really rich and thoughtful discussion. Can we all join in thanking our panellists? Thank you so much, everyone. So the next collaborative event will be held on the 23rd of May, and it will be a follow-on from an earlier session on the reanalysis of test results and some of the policy and ethical implications of that. So we'll be sending out more information about our next session in due course, and hope that you will be able to join us. That wraps up the proceedings for tonight. I think there may be some little sweet treats near the door for you to take with you on your way home, and we really look forward to seeing you at the next event. Thank you so much, everyone.